Assalamu alaikum and good evening to ladies and gentlemen. I am Dr. M. Saifuddin, Associate Professor, Department of Endocrinology, Dhaka Medical College and General Secretary, Bangladesh Endocrine Society. So today I'll talk on very important topics, MASLD treatment 2026 from evidence to prescription. My presentation consists of definition of MASLD already discussed by Professor Fariyapsana Madam, prevalence and incidence of MASLD, diabetes and MASLD, comprehensive lifestyle approach, drug treatment, revolutionary treatment, and some take home message regarding the management of MASLD at 2026. So definition has already been discussed. Three things is important. Number one, presence of hepatic steatosis. Number two, non-alcoholic or alcoholic below the cutoff limit. And number three, the exclusion of other diseases that may cause fatty liver disease. Spectrum has already been discussed, non-alcoholic fatty liver, MASH and HCCG. MASH may be early, fibrotic or cirrhotic, that is stage 4. Definition has already been mentioned. When there is evidence of hepatocellular injury, then it will be non-alcoholic fatty liver. But when there is evidence of hepatocellular injury, in that case is metabolic dysfunction associated steatohepatitis. It is the most common liver disorder in Western country, affecting 70 to 46% of the adult. Most common cause of chronic liver disease, commonest cause of asymptomatic abnormal liver function test, most common cause of end-stage liver disease. 7% of normal weight person, more frequently in female at younger age with normal liver enzyme, can also present as fatty liver disease. Incidence has already been shown, the same study at 2018 by Professor Shainul Alam sir, prevalence around 33.8%. Fatty liver disease estimated to be prevalent in 30 to 74% of the patient with diabetes. The reported prevalence of diabetes when the cirrhosis develops is 14 to 71%. And insulin resistance is one of the important factors related to development of metabolic dysfunction associated with steatotic liver disease. The all-cause of mortality is 2.2 times higher when it is associated with type 2 diabetes. Diabetes is a factor that helps in the progression to cirrhosis and hepatocellular carcinoma. So what's the treatment of MASLD at 2026 from evidence to prescription? Lots of evidence has been shown by my previous speaker, Professor Fariyapsana Madam. So comprehensive lifestyle approach, energy restriction. Calorie restriction is one of the important things, 500 to 1000 kilocalorie per day to induce a weight loss of 0.5 to 1 kg per week. At least 5% weight reduction is mandatory, but 10% is better. Long-term maintenance approach should be followed following weight reduction. Balanced diet is the ideal diet, need to be followed in a patient of MASLD. Adherence to Mediterranean diet seems to be the best one to reduce liver fat. Fructose intake should be discouraged. So Mediterranean diet is one of the important thing. It is a way of eating based on traditional cuisine on country bordering the Mediterranean Sea. Thus diet is high in vegetable, fruits, whole grains, beans, nuts and seeds, olive oil, and seasoning with herbs or spices. This is the statement taken from the Hadith. It is sufficient for a son of Adam to eat a few mouthfuls to keep his back straight. If he is must, then 1/3 of his stomach should be with food, 1/3 for his drink, 1/3 for his breath. So this is one of the best diet modification that I have got so far. I have studied. It's taken from Al-Tirmizi, Hadith number 2380. It is one of the Sahih Hadith. Balanced diet is the typical composition of carbohydrate 50%, protein 10 to 15%, fat less than 30%. This is the ideal diet that should be followed in MASLD patient, whether the patient has diabetes or not. This is the ideal balanced diet model. Half of the plate should be of vegetables, 1/4 by carbs and 1/4 by protein. But situation a bit different in our country, where you can see here around maybe 98 or 99% is carbs here. This is the typical good food of our country. Kachi bhai, kachi bhabi is there. I don't know whether they are related to each other or not. This is the comparison of the balanced diet and ketogenic diet, where the carbohydrate content is very low, only 5%, protein 20%, fat 75%. This is a review article published on the Nutrient Journal regarding the effect of ketogenic diet on steatotic liver disease. It has been shown that it significantly reduces hepatic fat content, improve metabolic parameter in the short term, but long term there are a number of adverse consequences like dyslipidemia, GI disturbance, transient keto flu, and increased risk of heart disease are the main limitation of ketogenic diet. Also, European Society of Cardiology stated extreme low carb or ketogenic diet are associated 51% higher risk of coronary artery disease, 50% cerebrovascular disease, and 35% higher risk of cancer. Intermittent fasting is a pattern of eating that alternate between designated window of feeding and fasting, which fasting lasts less than 2 days. There are different kinds of intermittent fasting. Most famous one is time-restricted eating, say for 16 into 8 means fasting for the 16 hours and 8 hours free feeding. Alternate day fasting, that means fasting one day, non-fasting another day. 5:2, that means patient will fast 2 non-consecutive days in a week, and rest 5 days patient may take a diet diet. And different review article has been shown that use of following intermittent fasting is associated with significant weight loss, reduced fat mass, improvement of the lipid parameter, improvement of the blood pressure. But American Heart Association published a paper where it has been shown that 8 hours time restricted eating is associated with 91% higher risk of cardiovascular death. So this is the main drawback of intermittent fasting associated with very high risk of cardiovascular diseases. Daily alcohol intake, better to avoid alcohol. Coffee consumption seems to be protective in MASLD as also liver disease of other etiology, reducing histological severity. Exercise or physical activity 150 to 200 minutes per week, moderate intensity aerobic physical activity seems to be important. And this is a review article published in Annals of Hepatology where it has been shown that regular coffee consumption is significantly associated with reduced risk of fatty liver disease. Also, it is associated with decreased risk of liver fibrosis development in already diagnosed MASLD patient. And it has been shown that mentioned at the review article, use of 2 to 3 cups of coffee per day is associated with better liver outcome. But in our country, before suggesting coffee to the patient, you should be aware that none of our patients, most of our patients are habituated with mixing sugar and milk, so you are getting not all the benefit related to coffee consumption. So in our practice, I usually don't advise the patient to take coffee. 10,000 steps per day, there are a number of benefits that had been shown by if you walk at least 10,000 steps per day. I am not going to discuss regarding details of regarding the benefit. And this is a advertisement at 1964 following Olympic Manpokei Podometer at the Japan, and this is their advertisement at 1964. Shortly after 1964 Olympic in Tokyo, there was a lot of attention on the fitness in Japan, and many local companies tried to profit of the hype. Yamasa invented a marketing ploy to sell a podometer to calculate how much you walk per day, and which literally translates 10,000 steps per day. Some even believe that the company chose 10,000 because the Japanese character of 10,000 is similar to this, that similar to a walking man, so they choose 10,000. And it has been shown that if you compare the people who steps say for 3 to 4,000 with 10,000, there is 40 to 50% lower risk of premature death over several years if you walk around 10,000 steps per day. So how to increase your daily step count? This is the statement or recommendation by the Mayo Clinic of the USA. When you unload groceries, carry only 1 or 2 bags into your home at a time, then go back and take another item, go back, take back another item. Always use the bathroom that is farthest from your current location. When you are on phone, use headset so that you can walk and talk. As much as possible, refuse to use walkway, accelerator, and elevator. Use the parking space that is far distance from your working space. When grocery shopping, you walk down every aisle rather than skipping the one that you don't need. Do a lap or 2 around a mall when you wait for your family member to try on clothes. Every 60 minutes or so, get up and move for a minute or so. These are the way how can you increase your step count in your day-to-day living. But don't touch every floor when you go for, in case of family shopping, don't touch each floor to increase the step count because to save your pockets. So drug treatment of the MASLD, there are lots of US FDA unapproved medication currently we are using in our clinical practice. One is vitamin E, usually recommended for person without diabetes, but their adverse effect seems to be overall mortality, increased chance of hemorrhagic stroke and prostate cancer more than 50 years. Obeticholic acid are associated with the higher risk of raised HDL cholesterol and pruritus, and it is US FDA recommended obeticholic acid only for primary biliary cholangitis in patients with advanced cirrhosis. Cellglitazole clinical studies in India and only not US FDA approved. Adverse effect are gastritis, asthenia, and pyrexia. Ursodeoxycholic acid, although some biochemical improvement, there is no histological improvement. Omega-3 fatty cholic acid is not a treatment for the MASLD, but you can use it when there is high TG in patient with MASLD. Obesity pharmacotherapy and bariatric surgery is very much important. When the patient present with BMI more than 27 kg per meter square with MASLD, you should try GLP-1 receptor agonist. Semaglutide 2.5 mg is the maximum dose, or liraglutide 3 mg per day. But when BMI is more than 30 or 27.5 for the Asian, you can suggest bariatric surgery. Endoscopic bariatric and metabolic therapy are not recommended in MASLD. Other obesity pharmacotherapy is recommended by US FDA lipase inhibitor, GLP-1 receptor agonist. Oral semaglutide has been approved for an MASLD just weeks back. Dual GIP and GIP combination, tirzepatide, we are commonly using in our clinical practice. Some anti-diabetic medication also gives you some weight benefit, like SGLT2 inhibitor, metformin or acarbose. Bariatric surgery when BMI is more than 30 or 27.5 for Asian American. And regarding the efficacy of anti-diabetic medication when the patient presents with diabetes, pioglitazone and GLP-1 receptor agonist, these two medications are associated with reduction of the liver fat and improvement of the steatohepatitis. SGLT2 inhibitor insulin are associated with liver fat, but effect is unknown regarding the disease activity. Metformin seems to be neutral in terms. Only one medication has got US FDA approval for the treatment of the MASLD, that is resmetirom. It is a thyroid hormone receptor beta agonist that binds with its receptor in the liver, and by increasing oxidation at the mitochondria, it reduces hepatic triglyceride accumulation and improvement of metabolic dysfunction associated steatotic liver disease. And it has got US FDA approval at 2024. It is indicated in adult with non-cirrhotic, non-alcoholic steatohepatitis with moderate to advanced liver fibrosis that is consistent with fibrosis 2 or 3 fibrosis stage only. So fibroscan liver with CAP, Dr. Professor Faryapsana madam has already shown you. So when liver stiffness is 7.8 to 11.6, that is equivalent to F2 to F3, these patients are ideal candidate for getting resmetirom. Avoid use of resmetirom in patient with decompensated cirrhosis or cirrhosis stage. You should better to avoid it. It can be given, the dose is dependent upon the body weight. If body weight is less than 100 kg, dose is 80 mg per day. If body weight is more than 100 kg, dose is 100 mg per day. It should be taken once daily with or without food. 60, 80 or 100 mg, but in our country, currently 80 or 100 mg is available. There is no contraindication. Hepatotoxicity is one of the warning and precaution. If the patient presents with sign of hepatotoxicity like fatigue, nausea, vomiting, right upper quadrant pain, you should check the liver function test, bilirubin, HGPT and total bilirubin, and you need to discontinue resmetirom up to resolution of liver abnormality. When there is elevation of immunoglobulin level, you can think of drug-induced autoimmune like hepatitis. Gallbladder-related adverse reaction, if cholelithiasis or cholecystitis present, you should not don't prescribe this kind of medication. But if cholelithiasis or cholecystitis suspected, you should better stop the medication. Adverse reaction are most common, GI adverse effect are most common, 2 to 3, maximum 5%, diarrhea, nausea, pruritus, vomiting, constipation, abdominal pain and dizziness. There are some drug interaction, yes, it is metabolized by cytochrome P450, so better to avoid with a strong cytochrome P450 inhibitor like gemcitabine. When the patient is getting clopidogrel, you may need to reduce the medication due to avoid increased chance of toxicity related to high concentration of resmetirom. Also, you should better to avoid use this kind of medication with cyclosporin. When the patient is getting very high doses of the lipid-lowering medication like statin, you should reduce the doses. For atorvastatin, you should limit the dose up to 40 mg. For rosuvastatin, you should limit daily dose up to 20 mg. Although in our country, we are using much lower dose than this recommendation. You should better to avoid use of resmetirom in patient with severe hepatic impairment. In child PO class B and C, it can be given in child PO class A without any modification, and it is not recommended to be used in NASH cirrhosis. Regarding child PO classification, I am not going to discuss depending upon the severe parameter, bilirubin, albumin, prothrombin time, ascites and hepatic encephalopathy. You should classify the patient regarding whether it is compensated cirrhosis or decompensated cirrhosis. In compensated, that means in A, you can use the medication, but in case of decompensated cirrhosis or child PO B or C, you should better to avoid this kind of medication. In pregnant women, lactating mother, pediatric patient, no available data, geriatric patient, You can use the medication, no problem, but if the age of the patient is more than 65, there is higher chances of GI adverse effect. In mild renal impairment, you can use the medication, and it has been not studied in patient with severe renal impairment. Evidence of Esmeterym use in the real world. This is a study published in the New England Journal of Medicine, most famous MASLD trial. This kind of medication is associated with the resolution of the mesh with fibrosis. It is conducted in 245 centers in the 15 countries. It is a double-blind randomized placebo-controlled trial. 966 patients was included in this study, and patients were randomized to Esmeterym 80 mg, 100 mg, and placebo, and liver biopsy was conducted at week 52. And it has been shown regarding mesh resolution, improvement of the fibrosis, and secondary endpoint was reduction of the LDL level at week 24. It has been shown that regarding mesh resolution, use of 80 and 100 mg of Esmeterym is associated with the improvement and resolution of the mesh in 25 to 29% patient. If you compare with the placebo, only 9.7%. Fibrosis score improvement in 24 or 25% patient. If you compare with placebo, 14%. Also, percent reduction of LDL seems to be much higher at the end of 24 weeks. Also, adverse effects are very minimum and comparable with placebo. So the key study findings was Esmeterym is superior to placebo regarding both histological primary endpoint, improvement of mesh and fibrosis stage, and change in liver parameter, liver biochemistry, and non-invasive steatosis and fibrosis assessment all favored Esmeterym. Take-home message of my today's presentation: MASLD is a rising concern nowadays. A good metabolic workup is crucial for good outcome of such patient. Good glycemic control in diabetic person along with management of other cardiovascular risk factor is mandatory. Weight reduction is one of the important steps for the better outcome of MASLD. Endocrinologists should be competent in the proper evaluation and management of MASLD. And Esmeterym indication, no biopsy needed, indicated for patient with mesh with mild to moderate fibrosis, that is F2 to F3. No biopsy requirement, biopsy needed, once daily dose, oral doses, simple dosing, no contraindication, no box warning, no monitoring requirement. So this is a very kind of safe medication. And thanks to Eskayef to invite me to deliver my presentation here. And thank you everyone for your kind attention. Thank you so much.